Well, good morning. It certainly is morning for me, about 6 a.m., and I'd like to get started with Chapter 30 on toxicology. It's a lengthy chapter, over 200 slides, so I'm going to break it into two pieces. And we'll start with this nice little introduction that poisonings present many challenges to you as an EMS provider. In general, we have to think of scene safety because the poisoning could be a hazmat situation, as in the case of chlorine spill or anhydrous ammonia or carbon monoxide, those sort of things. So whenever you are present and there are multiple people with the same symptoms, you need to think that perhaps this is a hazardous scene and protect yourself. Some poisonings, as an example, cholinergics, they cause a lot of secretions. So in those patients, managing the airway is a major challenge because of all the secretions. So they may present challenges with your ABCs. Some poisons do have antidotes, and you may or may not have the antidote. And then, of course, the best way to know is to call the Poison Control Center at 1-800-222-1222. 93% of the poisonings occur at home. 83% of the poisonings are accidental. And I think the thing to keep in mind about poisonings as well is that all things are poisonous. Water could be deadly if you drink enough of it. So everything around us is potentially poisonous. It just depends on the dose. Toxicology, then, is the study of toxins or poisons, particularly how they relate to humans. So it looks at the properties of the poisons, the effects of the poisons on the human body, by looking at the chemistry or the makeup of the poison or the toxin, the biochemistry, how it is degraded inside the body, and then the epidemiology, how likely this particular poison is found in any given area. Toxicology also combines the knowledge of chemistry, biochemistry, and epidemiology to look at things like why did the poisoning occur, how these poisons affect the human body, how we should treat victims, is there an antidote for this particular poison, and how to prevent further injuries. There's a variety of reasons that certainly could cause a toxicologic emergency. One is a therapeutic error on the part of perhaps a chemist or a pharmacist, a compounding pharmacist. We had a compounding pharmacist who made a tenfold error in preparing a particular medication for a patient and put 10 times the scopolamine in the medication than what was necessary, and the patient had a toxicologic emergency as a result of that. Idiosyncratic reactions, they may occur when you have multiple medications or multiple chemicals coming together to cause a problem. Environmental exposures, neglect and abuse, intentional drug and alcohol poisoning, suicide, and Tylenol is the number one drug of choice in patients who attempt suicide by overdose. Assaults, homicides, and terrorism may all lead to a toxicologic emergency. Poison control centers are around to help us. They maintain the United States has a national poison control center system. In addition to answering all your questions about a potential toxin or poison, poison control centers spend a great deal of time providing public education, conducting research, collecting data on what sort of poisonings they're seeing in their area, and establishing a database. And the Iowa Poison Control Center is located out of Unity Point in Sioux City, Iowa. And that phone number is, as I had mentioned, 1-800-222-1222. Our state protocol does suggest that when you're dealing with a poisoning, that you call the Poison Control Center, because they're going to have the latest and the greatest information on how to care for that patient. There's a variety of ways that toxins and poisons can get into our body. One is ingestion, and that's through eating or drinking. It's the most common way for most poisons to get into our body. It's very effective in getting poisons into our body because the GI system will break down and absorb the toxin or the poison, and the stomach and the GI tract. They call it an equal opportunity absorber. It doesn't differentiate between things that are good for us and things that are bad for us. Acids are better absorbed in the stomach, and bases are better absorbed in the small intestine. So depending upon the poisoning, if it's an acidic poison, then that's absorbed more in your stomach. If it's a stronger base poison, that's absorbed more in the small intestines. And poisons must be in water to be absorbed in the GI tract. Absorption is another route of entry of the poisons, and that's through the skin or the eyes, particularly the eyes. The eyes are not well protected when it comes to things like a chlorine gas or any sort of splash in the eye. They're not really well protected. The skin's a pretty tough barrier to absorption, and one of the types of chemicals that we certainly see being absorbed through the skin or getting into the eyes is your hydrocarbon solvents and fuels being gasoline, kerosene, diesel, any of those sort of things left on your skin long enough certainly can be absorbed into your skin. Injection is when the poison or toxin is injected into the body. It could be accidentally through a puncture, as in the case of a significant exposure. It could be intentionally through a needle, like a penicillin shot in somebody who's allergic to penicillin, or perhaps envenomation from a snake or spider. Drug abuse is probably the most likely reason for a toxicologic emergency related to injection. Hydraulic fluid can be injected through pinholes in hydraulic lines and cause nasty, devastating injuries that may appear quite small on the outside of the body, but when that hydraulic fluid is, in addition to being extremely hot, injected under great pressure into your skin and tissue, it causes a lot of necrotic damage. And then, of course, injections in the form of shots getting into your bloodstream. Inhalation is when we breathe in the fumes. And again, the lungs cannot discriminate between life-giving oxygen and toxic gases. So when we breathe in, as an example, carbon monoxide, we know that that has a stronger affinity for the hemoglobin molecule, and we could suffocate as a result of that. Same thing with hydrogen cyanide that is found in smoke from burning buildings. If you breathe enough of that in, it certainly can cause asphyxiation as well. When you breathe something in, the toxic gas, it rapidly enters the bloodstream at the alveoli in the lungs. And then depending on the type of gas, as an example, chlorine, if you breathe in chlorine gas, it combines with the moisture in your respiratory tract and forms hydrochloric acid. And that certainly can burn the lung tissue, leading to lung damage and the development of acute pulmonary edema. Recognizing and identifying poisoning accidents. Again, remember, scene safety for yourself and the patient is dependent on how rapidly and accurately the poison is identified. Toxidromes, and we'll talk about specific toxidromes here in just a bit, is one way to identify the toxin. It may be information that's relayed to you, and once you know what the particular poison is, you may be able to administer an antidote. Some toxins can lead to delirium, and delirium can lead to violent behavior. As far as scene size up and the responder safety goes, sometimes we might be able to tell the type of toxin that we're dealing with based on the location if we know what's going on at the location. If we get dispatched to a location where we know they're housing certain chemicals, large paint booths, polyurethane, plastics, and those sort of things, that might give us an idea that that's what we could be dealing with. From the dispatch information, you should get some sort of primary complaint, and we know that's not always accurate, but certainly understanding what symptoms the patient is complaining of may help us identify the poison as well. Determine whether it's accidental or intentional. Certainly accidental is the vast majority of poisonings. We looked at that being 83% of all poisonings are accidental. And then call the Poison Control Center early if you think you're dealing with a specific toxin. Something to keep in mind as well is that in patients who attempt to commit suicide, in drug overdoses, in other situations, you may be dealing with a crime scene, and it's important that law enforcement secure the scene before you enter. And if you get there and law enforcement isn't available, and you believe the scene is potentially dangerous, obviously don't go in. Back out and call for law enforcement. If you're dealing with a chemical release or a spill, that would require you to let's see, let me close that. There we go. If you're dealing with a chemical or a spill, that would certainly require you to recognize that you're dealing with that chemical or spill, avoid coming in contact, isolate yourself, and notify the proper authorities that have the training to deal with a hazardous materials spill. The NFPA requires as a minimum that EMS providers have at least awareness training so that you can identify you're dealing with a hazardous scene and then back out and notify the proper hazmat team to come in and assist or come in and take care of the hazard while you await to take care of decontaminated patients. We know that in most situations that if a patient's eyes are watering and their lungs are burning and they can't breathe and an ambulance shows up before a hazmat team gets there, they're not going to wait. They're going to be coming at the ambulance for help. So at least the vast majority of EMS providers that I'm aware of are trained at the operations level so that they can do decontamination prior to treating the patient. There's some reference materials that we can use when trying to seek out the type of poison and identifying it and determining what sort of personal protective equipment we need, as well as what sort of treatment the patient may need and whether or not there's a antidote. And certainly the NIOSH guide will be helpful. It'll give you the chemical and physical properties of the agents. It'll outline respiratory guidelines. It'll tell you the long-term health effects. It'll identify immediate treatment regimens. The chemicals are listed alphabetically, and you can also look it up by the UN number or the chemical abstract services number. WISER is another chemical database. It's an electronic database. It'll give you the chemical and physical properties, the decontamination advice, treatment guidelines. There also is a search engine within WISER that you can search by the signs and symptoms or chemical and physical properties. And WISER can be downloaded to PDAs, laptops, tablets. You can find it online. I'm sure there's a app for that as well. The Agency for Toxic Substances and Disease Registry, EMS and hospital responses to hazardous material poisonings. It just outlines what EMS and the hospital's responses to these should be. And then obviously your Poison Control Center. As far as patient assessment and history goes, you're going to do an initial assessment like you would any patient to find out their chief complaint, your general impression. In their chief complaint, try to determine the substance to which the patient is exposed, how it got into their body, the amount they were exposed to, excuse me, and the exposure onset. You're going to do your primary assessment, which includes your ABCs, and control any immediate life threats, and then look for signs and symptoms that might be seen with specific types of poisonings, or at least note the signs and symptoms that they have and try to match them to a particular type of poisoning. Poisoning certainly may cause altered mental status, may cause trouble breathing, may cause cardiac arrhythmias, vomiting, diarrhea, those sort of things. Determine whether or not the patient has any sort of psychological illness, which might tie this particular exposure to the toxin or the drug overdose to a psychological illness. If the patient is unresponsive, certainly we have to try to gather information from bystanders. Has the patient, taken anything like Ipecac prior to your arrival, or has anybody given them activated charcoal prior to your arrival? Those are things that we don't even have in the state protocols anymore. When we look at emetics like Ipecac, those are things that are going to make you throw up. The belief was that if you ingested something and I made you throw up, you'd empty your stomach and those things wouldn't be absorbed into your bloodstream, and we'd do good. But the reality is, anytime you force somebody to throw up with a medication, especially if their mental status is altered in any way, the risk of aspiration is just too great. So the risk outweighs the benefit, and so Epicac's not in the state protocol, and most services don't carry it. As far as activated charcoal, again, many patients who take activated charcoal vomit, and in doing so, the risk of aspirating the activated charcoal far outweighs the benefit, because most people will wait several hours if they've intentionally overdosed, or most poisonings aren't discovered until several hours later, and by then there's nothing in the stomach. It's already into the small intestine and being absorbed into the bloodstream. Look around for containers and medications, and if the patient vomits, particularly depending on the type of poison they may have ingested, be really cautious or careful around the emesis. Toxidromes are signs and symptoms that different toxic agents induce. So by understanding that if I'm exposed to this particular chemical, I'm going to have these signs and symptoms, that helps us rapidly identify the toxin and potentially an antidote. Toxidromes are classified according to the signs and symptoms that they induce, and by again identifying them, that helps us provide treatment and a specific antidote. The first toxidrome that we're going to look at is called a cholinergic toxidrome, and these include pesticides and nerve agents. Now, pesticides are things like Dursban, Lorsban, Furadan, malathion, Ortho-7. Those are designed specifically to kill bugs, but they also kill people if they are exposed to enough of them. The deadly nerve agents, the weapons of mass destruction like sarin, soman, tabin, VX, the Novichok agents that the Russians have, and gosh knows what the United States has. But those toxins, pesticides and nerve agents, when a person is exposed to them in enough amount, will sludge them. And sludge them is an acronym that we use that describes salivation. They make more spit than you thought humanly possible. Lacrimation, they're crying or tearing. Urination, their bladder becomes full and distended. Defecation, they have diarrhea. G is gastrointestinal upset. E is emesis, and M is meiosis, or pinpoint pupils. They're also going to be sweaty. They're going to have an altered mental status, confused and weak, nausea and vomiting, abdominal cramping. In addition to bronchoconstriction, they'll also develop bronchorrhea because of the excess mucus production. And then they may have cardiac dysrhythmias, convulsions, seizures. They may have fasciculations, paralysis, coma, and then death. So it's not a pretty way to die, and these pesticides and nerve agents are quite effective in accomplishing that. Treatment for a cholinergic exposure is you're going to have trouble with the ABCs just because of all the secretions. I don't know if anybody in the class has been to boot camp or has heard the horror stories of time in the gas chamber as part of boot camp. But when you come out of that gas chamber, which I have been in, you make more spit and snot than you thought humanly possible. Your eyes are watering, your skin's burning, you can't breathe. And that was just a small exposure to actually a riot agent. Really didn't have anything to do with a cholinergic. So lots of secretions. You're going to have trouble managing that. Activated charcoal, if they ingest it, perhaps if you're there within the first hour, but you'd have to call poison control to see if that's something that they would recommend. Atropine and pralidoxime, or 2-PAM chloride, are the antidote for a cholinergic exposure. And the normal dose of atropine is 0.5 milligrams. Well, we're going to double the dose until the patient dries up. Because atropine is an anticholinergic. It's going to bind with the excess acetylcholine. It's going to occupy the receptor sites on the organ for acetylcholine. And it's going to dry them up and reverse the effects of the cholinergic toxidrome. So atropine, being an anticholinergic, will double the dose until they're dry. Dr. Ed Bowtie from the Poison Control Center in Sioux City tells a story of a gentleman who had lice, and he wanted to kill them, so he thought he would take a bath in a pesticide. So he poured some malathion into his bath water, and as he laid there in the malathion, of course, it absorbed in through his skin with that warm water, dilating his pores. It quickly absorbed in through the skin, and he was having grand mal seizures in the tub when his wife found him, called 911, and they, of course, started giving atropine and continued to give him atropine. And in that first 24 hours, it took 64 milligrams of atropine to dry him up. So, if you have a patient, you're going to give them 1 milligram, and 2 minutes later, or 3 to 5 minutes later, you're going to give them 2 milligrams, and 3 to 5 minutes later, you're going to give them 4 milligrams, and 3 to 5 minutes later, you're going to give them 8 milligrams, and 3 to 5 minutes later, you're going to give them 16 milligrams, and when you start thinking about that, that's just one patient. And we don't carry enough atropine to effectively manage one patient with a significant cholinergic toxidrome. And that's why there's such great fear with these weapons of mass destruction, these deadly nerve agents, because should they be deployed, we don't have the antidotes to treat the patients. Pralidoxine, 2-PAM chloride, that works best on organophosphates. It doesn't work well on carbamates, which I believe would be ortho 7, and furidan, if I'm not mistaken. It just doesn't work well on those types of pesticides, and the 2-PAM chloride works best if given within the first hour of exposure. The 2-PAM chloride binds with the toxin and is eliminated then out of the body. Certainly if they have seizures, some sort of benzodiazepine would be appropriate, whether it's Valium or Versed or Ativan. Now, an anticholinergic toxidrome or an anticholinergic is just the reverse. If a cholinergic toxidrome makes you wet, then an anticholinergic toxidrome makes you dry. And anticholinergics include things like atropine, dramamine, scopolamine, Benadryl, Sudafed, Atrovent, Spiriva, Haldol, psilocybin, standard yard variety mushrooms, tricyclic antidepressants, are all anticholinergics. And so when somebody is exposed to an anticholinergic and are poisoned by anticholinergics, the signs and symptoms that you're going to see include dry skin, flushed skin, extremely thirsty because of how dry they are, they're delirium, they're lethargic, they have difficulty swallowing, again because of how dry they are, their pupils are dilated, so they have trouble seeing, their temperature's up, their heart rate's up, their cardiac arrhythmias, particularly tachyarrhythmias, can present, and seizures. I think one of the common things that people say about this particular toxidrome is when describing it, they're dry as a bone, red as a beet, mad as a hatter, blind as a bat, full as a flask. Those are some descriptors that they use to, hot as Haiti is another one they throw in there. So that's a descriptor of the signs and symptoms of an anticholinergic toxidrome. Treatment is going to be ABCs. Again, I would contact Poison Control Center to determine the need for activated charcoal. And the antidote for an anticholinergic syndrome is physostigmine. And physostigmine makes them wet. Physostigmine is a very potent cholinergic. And it really isn't anything we give in the field. And rarely have I seen it given in the hospital, because you can easily throw the patient from being too dry to being too wet. So it's one of those that has to be closely monitored when given, and only for significant anticholinergic overdoses. Certainly for seizures, any sort of benzodiazepine. Hallucinogen syndrome is another type of toxidrome that we don't see as much as we used to, because when you look at the hallucinogens, you have peyote, which is something the Indians used to smoke and consume to cause them to hallucinate. PCP or angel dust, LSD, magic mushrooms or psilocybin. These are all hallucinogens, and the signs and symptoms are visual illusions, strange behavior, and delusions. If they get enough, they can lead to respiratory depression and CNS depression. But typically on these hallucinogens, the big concern is their strange behavior and their delusions. In other words, oftentimes when taking these, whether intentionally or somebody slips them into their drink or mix or those sort of things, they often think that they can fly. And so jumping out of a third or fourth story window is not something that's uncommon. Or they think they're super strong and can stop a train. So, they jump out onto the train rails and try to stop the train. And obviously, these hallucinogens don't give them superhuman strength or superpowers, but they often believe they have them when taking these hallucinogens. Treatment is supportive, calming measures. They may be hallucinating horrific things as well. Typically, they're hallucinating wonderful things, but they can be hallucinating things like spiders and bugs and snakes and things like that. So, trying to calm them down, trying to refocus where they're at and what's occurring. One of the worst things, of course, that you could do would be to, if they're seeing spiders and snakes, to agree that you see them too, because that'll just freak them out. And, of course, for seizures, you want to give some sort of benzodiazepine. Narcotic opioid syndrome. This occurs when people ingest heroin, codeine, morphine, and any of the morphine derivatives. Oxycodone, hydrocodone, any of the codeine derivatives, Percodan, Percocet, any of those. Demerol, Quaaludes, benzodiazepines, barbitals like phenobarbital. So a narcotic opioid syndrome, with these, the signs and symptoms are a classic presentation. You'll have look for three things with this particular syndrome: pinpoint pupils, altered mental status, and respiratory depression. When you see that patient whose mental status is depressed, they're difficult to arouse, they're breathing very slow and shallow, and their pupils are pinpoint, you've got a narcotic opioid syndrome. Treatment is Narcan. While we're not seeing a huge increase in heroin use in our part of the state, I know that in parts of Iowa they are, and in other states they are as well. With the strict regulation of painkillers, like your morphine derivatives and your codeine derivatives, with those being strictly regulated, the actual street price for those drugs are more than the street price for heroin. So we're seeing more and more people using heroin instead of the oxycodone, the hydrocodone, those sort of things. And because of that, nationwide, heroin overdose is a major ensuing problem. In 27 states, EMTs and law enforcement officers can give intranasal Narcan. In 17 states, family and friends can take a 15-minute class and be taught how to recognize the signs and symptoms of a heroin overdose and how to administer 1 milligram of Narcan up each nair with a intranasal atomizer. Sympathomimetic syndromes. Sympathomimetics mimic what happens when you stimulate the sympathetic nervous system, the fight or flight nervous system. So with the sympathomimetic syndrome, that includes cocaine, methamphetamine, ecstasy, bath salts, caffeine, nicotine, and the signs and symptoms, everything is up. When you've got that patient who is paranoid, who's hot, sweaty, tachycardic, hypertensive, and CNS excitement and twitching and tweaking and those sort of things, you're looking at a sympathomimetic syndrome. Treatment is going to be managing their ABCs, calming them down the best you can. I mean, depending on the type of drug that they've taken and the amount that they've taken, there may be they may not be able to be talked down at all. So you may have to rely on large doses of benzodiazepines. It's not uncommon to give somebody with a sympathomimetic overdose 20 to 40 milligrams of Valium in order to get them to calm down. Also remember, as importantly as calming them down with the benzodiazepine, we got to bring their temperature down too, because they can have high enough temperatures to fry their brains. So to incorporate cooling measures along with the benzodiazepines is important for sympathomimetic overdoses. Some general treatment principles include determine the agent, be persistent during the history to get what that agent is. Those people certainly using illegal drugs are not likely to give you that information. Use family, friends, and bystanders to get information as well. Look around the environment to give you some clues as to what might be going on. Is there any open or partially empty containers? Look in the medicine cabinet to find the doses of medications that they may be on. Look for chemical residues around the mouth and nose, and if they're huffing or doing any of those things with hydrocarbon solvents. Look for drug paraphernalia that certainly might indicate the type of drug that they're using. Low viscosity solvents are prone to aspiration, so be aware of that. And then obtain IV access or IO access. You might have to do some decontamination depending on the type of chemical that they've been exposed to. That should be done before you put them in the ambulance. They're saying that patients who have ingested volatile poisons should never be transported by air. Not sure why that recommendation is. I'm going to have to do some research on that. Volatile poisons would be very strong acids, like drain cleaners, like hydrochloric acid or battery acid, ingestion, those sort of things. Most all your fire departments can do decontamination. Many of your EMS systems can do decontamination. And the universal decontamination process is to remove and isolate the clothing in a bag, which is going to eliminate 80% of the contaminant, and then soap and water. Any kind of dish soap, because it's non-phosphorus and because it does a good job in breaking down the oils. Some chemicals are more persistent than others, and what that means is that they're more oily, they cling to the skin and clothing more, so using a good soap that's known to break and dissolve oil like Dawn or Dove or Ivory, dish soap, and lots and lots and lots of water. As far as GI internal decontamination, that should occur within 1 hour. Obviously, if it's been 3-4 hours, those sort of things, then the toxin's no longer in their stomach. Once the toxin reaches their small intestine, then emptying the stomach, of course, is ineffective. Syrup of ipecac is typically what is used if within the first hour, and even though that's available, as you can see there, it's universally discouraged because the risk of aspiration far outweighs the benefit of emptying the stomach. And by emptying the stomach, you only reduce absorption by 30%. Activated charcoal is another way to do GI decontamination. It's as effective as pumping the stomach. It does absorb most of the chemicals, but it's got to be administered within that first hour of ingestion. Many of the activated charcoal solutions have cathartics added to them, like sorbitol. A cathartic will make you poop. so it increases the elimination rate of the activated charcoal. Gastric lavage is certainly something that is still somewhat being done in some locations, and that's pumping the stomach. Again, it's most effective if performed within the first hour of ingestion, and it only decontaminates the stomach. So it really isn't effective once the toxin reaches the small intestine. It is an excellent treatment for poisons that do not bind to activated charcoal or highly toxic agents without an antidote, but again, if done within the first hour of ingestion. Contraindications to gastric lavage, of course, include an altered level of consciousness and ingestion of low viscosity hydrocarbons or corrosives. So in other words, medications that burn all the way going down, they may burn coming back up if the patient were to vomit while you're trying to pass the OG tube and pump their stomach. But it isn't the burning coming back up that's a concern. Again, it's that risk of aspiration. Complications include, as you're pushing that OG tube down their throat, it could end up in their trachea, and you would hate to lavage the lungs. Aspiration pneumonitis, which could be deadly, and esophageal perforation with the tube itself. Whole bowel irrigation is much more effective. Poisonings that form concretions like salicylates, aspirin, iron, those sort of things are better managed with whole bowel irrigation. There are also whole bowel irrigation is good for substances that aren't readily absorbed by activated charcoal. And whole bowel irrigation is accomplished by continuously administering a polyethylene glycol electrolyte into the stomach with a gastric tube, and the contents of the entire GI tract then are cleared. Drawback is the amount of time it takes to continuously administer the fluid until the GI tract is cleared. Antidote administration. Antidotes counteract the effects of the poison. They help increase the elimination rate, and they reactivate enzymes that may be damaged by the poison. We'll look at some specific types of medication poisonings here. Drug overdose, of course, the number one drug that people overdose on is acetaminophen. 80% of all drug overdoses involve Tylenol. Sedatives, hypnotics, antipsychotics, antidepressants, analgesics are all medications that people may overdose on. Accidental overdose, they're going to have a low therapeutic index of the drug in their system. This would be the situation where you may have an elder patient who takes 5, 6, 7 drugs, and they forget that they've taken their medication. They aren't sure, so they go ahead and double up their dose. And if they do that several times during a week, they could have a very low therapeutic index of this drug in their system, but still be higher than than normal. The treatment for accidental overdose, or what we call polypharmacy, is to focus on prevention. Reading the instructions with the medications, storing the medications in a safe place, using dosed and dated pill boxes so that patients know what meds they've taken that day. Treatments for medication overdose is supportive care, managed life threats, and the antidote varies depending upon the drug that they've overdosed on. Pain relievers, acetaminophen signs and symptoms comes in 4 stages. Stage 1 is 0 to 24 hours, an acetaminophen overdose, and you want to remember the number 150. A toxic dose of acetaminophen is if a patient has ingested more than 150 milligrams per kilo. If they've ingested more than 150 milligrams per kilo, that's a toxic dose of acetaminophen. So in that first stage, in that first 24 hours, an acetaminophen overdose will cause weakness and fatigue, nausea and vomiting, sweating, pale. In stage 2, the next 24 to 48 hours, they're going to have abdominal pain, decreased urine output, their liver is going to start to show signs of damage by an elevated liver enzymes. In the next 3 days or so, the patient becomes jaundiced, develops dysrhythmias. Because the liver's not working properly and you're not able to store and convert sugar, hypoglycemia may occur, lethargy and vomiting, and in the fourth stage, anywhere from 4 to 14 days after the ingestion, the liver shuts down, it fails, and the patient may die. So an acetaminophen overdose accounts for 80% of all drug overdoses, and it really destroys the liver. And maybe not right away. It may take up to 2 weeks following the ingestion, particularly a dose over 150 milligrams per kilo. But it's a terrible way to die, and it's a very slow and painful way to die over a period of about 2 weeks. And if they survive the Tylenol acetaminophen overdose because they didn't take that toxic amount, it still may cause some liver damage, which will shorten their life. The treatment for acetaminophen overdoses include supportive ABCs. Try to get a good history. Try to determine the time of ingestion. Check with poison control on the administration of activated charcoal. Again, most effective within that first hour, and again, most people who overdose on acetaminophen are going to wait 2 to 3 hours before they even call. The antidote is something called N-acetylcysteine, and it helps bind the acetaminophen and prevent it from being absorbed into the bloodstream. Salicylates, these would be things like aspirin. When a person overdoses on a salicylate, they develop rapid respirations, confusion and lethargy, abdominal pain, vomiting, and while you wouldn't think it, they develop a high temp. We take salicylates to lower our temperature, but in an overdose situation, they're going to raise the temperature. They may develop dysrhythmias, go into heart failure, coma, and death. Treatment is supportive. A detailed patient history. Note the time of ingestion. Contact poison control on whether to administer activated charcoal. Flush with fluids are important for salicylate treatment as well. NSAIDs would be your non-steroidal anti-inflammatories. Those would include things like ibuprofen, naproxen sodium, so those type of medications. They too are really hard on both the liver and the kidneys. So signs of an NSAID overdose would include headache, ringing in the ears, nausea and vomiting, drowsiness, swelling of the extremities, rash or itchiness, shortness of breath or wheezing, pulmonary edema, and liver and renal failure. Treatment is supportive. Again, get as good a history as you can to include the time of ingestion. Contact poison control for the need for activated charcoal, and monitor for low blood pressure and cardiac arrhythmias. Tricyclic antidepressants. Tricyclic antidepressants were a first-generation antidepressant, and while they worked well, tricyclics were highly addictive, and oftentimes given to people with depression. They were commonly used in overdose situations in people who took tricyclics. And as a result, we're into our third and fourth generation of antidepressants. We have much better antidepressants that have not the addictive properties nor the horrific outcomes when you overdose on them. Signs and symptoms of a tricyclic antidepressant overdose include anticholinergic signs, blurred vision, confusion, hallucinations, respiratory depressions, cardiac dysrhythmias, particularly PVCs. Not sure why, but patients who overdose on tricyclics will start throwing lots and lots of PVCs, and in that particular case, rather than giving a antiarrhythmic like amiodarone or procainamide or lidocaine, the treatment is sodium bicarbonate. It's not known why, but slightly alkalinizing the blood helps get rid of the PVCs. They may develop hypotension, seizures, and death. Treatment is supportive. Get, again, as good a history and time of ingestion as you can. Contact poison control for the need to administer activated charcoal. Put them on a cardiac monitor to look for those PVCs. And should they be throwing lots of PVCs, alkalinization with sodium bicarbonate at 1 milli equivalent per kilogram. Some may advocate the use of romazicon or flumazanil, which is the same thing, to reverse the effects of a tricyclic antidepressant overdose. But if you reverse the effects of a tricyclic overdose in a person who has taken tricyclics for a long time, they'll go through rapid withdrawal symptoms, which include seizures. And the treatment for seizures is a benzodiazepine. And flumazanil blocks benzodiazepines, so you wouldn't be able to control the seizure if it occurred. Lithium is another antidepressant given primarily to people with bipolar disorder. Signs and symptoms of lithium overdose include thirst and dry mouth, nausea, vomiting, and diarrhea, blurred vision, slurred speech, confusion, tremors and fasciculations, dysrhythmias, particularly bradycardia, stop breathing, or seizures or coma, and potential renal failure. Treatment for lithium, like other antidepressants, is going to be supportive. Get a detailed patient history, find out the time of ingestion. IV fluid replacement is important. Alkalinization of the urine with sodium bicarbonate may be helpful. And then activated charcoal is ineffective. But if they've co-ingested something else, if they've taken lithium and a tricyclic, or lithium and something else, maybe the activated charcoal would work on that something else. MOA inhibitors, or MAO inhibitors, MAO inhibitors are an older antidepressant, first generation antidepressant. They still exist, but fewer and fewer people are on them. Signs and symptoms of an MAO inhibitor include headache, agitation, ping-pong gaze, palpitations, diaphoresis, hypertension and hyperthermia, tachycardia, and with significant overdose, bradycardia, hypotension, coma, and death. Treatment for an MAO inhibitor overdose includes being supportive with the ABCs, get a really detailed history, note the time of ingestion. If they're extremely hot, cool them down, monitor their heart rate, call poison control on whether or not to administer activated charcoal. Should they have seizures from the MAO inhibitors, or from the really high temperature, then certainly benzodiazepines, whether it be Valium, Versed, or Ativan, would be the drug of choice here. For hypotension, a pressor is what you're going to need rather than fluids. So something like Levophed or norepinephrine to cause significant vasoconstriction to bring the pressure up in the system. The antagonist for MAO inhibitors is a drug called cyproheptadine. SSRs, this is the third generation antidepressants. They're serotonin selective reuptake inhibitors, so SSRIs. People can develop what's called serotonin syndrome, more so not from overdose, because it takes a lot of an SSRI to actually overdose on. In fact, a single prescription, if they took all 30 pills, they wouldn't overdose on them. And that's what's safe about them. But however, rapid withdrawal from an SSRI is where you get into trouble. If somebody thinks they're feeling really well and they don't need this antidepressant after taking it for quite a while, they can develop serotonin syndrome. And that includes agitation, anxiety, confusion, headache and drowsiness, sweaty, nausea and vomiting, increased salivation and diarrhea. Their skin may be flushed. They may develop cutaneous piloerections or goosebumps, shivering, tremors, jerks, high fevers, sinus tachycardia. Their muscles may become rigid with a lack of coordination, and because of the excess diarrhea and vomiting, they would have hyperactive bowel sounds. Treatment for SSRI overdoses include, again, being supportive, get a really good detailed history and time of ingestion, reverse the high temperature, call poison control on the need for activated charcoal, monitor their cardiac rhythm, and the antidote would be a serotonin receptor antagonist. Benzodiazepines are part of the group of sedatives, hypnotics, and antipsychotics. We use benzodiazepines, of course, for a variety of important reasons as a EMS provider, as a paramedic, but benzodiazepines also can be drugs of abuse in patients looking for a sedative or a hypnotic. Signs and symptoms include drowsiness, staggering gait, slurred speech, respiratory depression, hypotension, hypothermia, bradyarrhythmias, and coma. Treatment is supportive. If they're breathing really shallow, assisting their ventilations, administering oxygen, establishing an IV, getting a good patient history to include time of onset of ingestion, call the poison control for the need for activated charcoal. Again, works best if given within the hour. The antidote is flumazenil or romazicon. And if I have a person who is not a benzo junkie and maybe got a hold of somebody's benzodiazepines and overdosed on them, I wouldn't really feel I wouldn't see any problem with giving romazicon. But if I've got a chronic drug abuser whose drug of choice is a benzodiazepine, and I give them the romazicon to reverse the effects of the drug, again, that would equal a quick withdrawal to their drug of choice, so they can go through all the common things that you see in patients who go through delirium tremens, with the sweating, the delusions, the seizures, and of course if they seize and you've given the romazicon, you're not going to be able to stop their seizure with a benzodiazepine. Barbiturates are also part of sedatives and hypnotics and antipsychotics. Barbiturates primarily like phenobarbital. Signs and symptoms include lethargy, drowsiness, staggering, slurred speech, emotional volatility, respiratory depression, fixed and dilated pupils, hypotension, fever, shock, and coma. Antipsychotics, signs and symptoms include sedation, include pinpoint pupils, dysrhythmias, hypotension, tachycardia, and seizures. Treatment for the last two is being supportive. Support the ABCs, get a detailed patient history, good thorough sample, particularly noting the time of ingestion, and contact poison control for the need for activated charcoal. Some cardiotoxic drugs that a person may overdose on, probably inadvertently, would include something like a calcium channel blocker, or perhaps a small child who got a hold of, their parent or grandparents' calcium channel blocker. In those situations, it could be, what we call a one-pill kill. Signs and symptoms of a calcium channel blocker overdose include sedation, confusion, slurred speech, nausea and vomiting, low blood pressure, respiratory depression, pulmonary edema, hyperglycemia, hyperkalemia, lactic acidosis, cardiac dysrhythmias, atrioventricular dissociation, sinus arrest, bradycardia, coma. And the treatment for calcium channel blockers, of course, is calcium chloride or calcium gluconate. Put more calcium into the system, and hopefully they will occupy an open spot or an open receptor on the organ that isn't blocked by a calcium channel blocker. Treatment supportive, oxygen, get a good history, noting the time of ingestion as well as perhaps the amount of a calcium channel blocker. Call poison control about activated charcoal, IV and heart monitor. For dysrhythmias, you could give antidysrhythmics, and low blood pressures you can give vasopressors. But the antidote is going to be calcium chloride or calcium gluconate. If you don't have that, certainly you could try atropine, pacing, glucagon if they're hypoglycemic, and glucagon also not so much for the hypoglycemia, but glucagon has been shown in some people. It's not real effective, but in some people it does accelerate the heart rate by not. It doesn't do it by stimulating the beta-1 receptor sites on the heart, which typically is what has to occur for the heart rate to speed up. But glucagon, for some reason, does cause the heart rate to speed up in some people. Beta blockers, those are your LOL drugs. Signs and symptoms include bradycardia, hypotension, respiratory depression, seizures, unconsciousness, coma, and death. Again, beta blockers are used to slow the heart rate down and lower blood pressure in patients who are hypertensive and tachycardic. Treatment for beta blocker overdose includes being supportive, IVO2 monitor, getting a good history, again, time of ingestion, the amount ingested, call poison control to determine if activated charcoal is necessary. The antidote is glucagon, calcium chloride, calcium gluconate, atropine, pacing, and potentially dopamine. And again, glucagons, for an unknown reason, may in some people allow the heart rate to pick back up. Cardiac glycosides like digitalis, digoxin, digitoxin, these drugs are drugs that the dose is very patient specific. These drugs can lead to toxicity relatively easy. Therefore, patients who take dig preps often have to have their blood drawn monthly to see what their dig level is. Signs and symptoms include fatigue, visual disturbances, nausea and vomiting, GI disturbances, not eating, heart arrhythmias, hyperkalemia, could be a consequence of dig-tox as well. Treatment is supportive, again, good history, the time of ingestion and how much, call poison control about activated charcoal, and the antidote is a digoxin specific fab, which helps bind with the digoxin and lower the dig levels in the blood. Anticonvulsants include things like carbamazepine, something like that. Bamazepine is what I want to say bamazepine. Carbamazepine. There we go. Carbamazepine. Carbamazepine, signs and symptoms, the drug is going to have anticholinergic effects, so it's going to dry people up. There'll be movement disorders, cardiac dysrhythmias, respiratory depression, hypotension, and coma. Treatment is, again, supportive, get a good patient history, time of ingestion, the amount they've ingested, call poison control about activated charcoal, and because it can cause arrhythmias, monitoring the heart. You'd also establish an IV and those other things that are supportive. Some other anticonvulsants, including phenytoin or hydantoin derivatives. The signs and symptoms include nystagmus, headache, ataxia, CNS depression, respiratory depression, coma. Phenytoin would be dilantin. Treatment would be supportive, again, detailed history, IV access, and perhaps activated charcoal. Valproic acid would be Depakote. Valproic acid or Depakote, another anticonvulsant. Signs and symptoms would be drowsiness, CNS depression, respiratory depression, hypotension, hypoglycemia, hypocalcemia, hypernatremia, metabolic acidosis, cerebral edema, and coma. So this seems to be worse than some of the other anticonvulsants. Treatment is going to be like all the other anticonvulsant overdoses, supportive. Manage the ABCs, get a good history to include the time of ingestion and the amount, IV access, O2 if necessary, monitor the heart rate, and then contact poison control for the need to administer activated charcoal. Antihistamine and asthma medications include diphenhydramine. Diphenhydramine, or Benadryl, is going to be a anticholinergic, so they're going to be dry, a very, very dry patient. They're going to be sedated, respiratory depression, dry, nausea and vomiting, dilated pupils, high temperature, low blood pressure, cardiac arrhythmias, and seizures. Treatment is supportive, get that good detailed history, time of ingestion, and amount of the Benadryl that they took, cool them down, IV fluids, cardiac monitor, and again, physostigmine would be the antidote for this, but it's not something we give pre-hospital. Theophylline, a medication to help you breathe easier. Signs and symptoms for theophylline overdose include agitation and tremors, nausea and vomiting, diarrhea, hypotension, hypercalcemia, hyperglycemia, clonic posturing, so muscle twitching, intracranial hemorrhage, and seizures. Treatment is supportive, IVO2 monitor, good history, the time of ingestion and how much, activated charcoal if poison control tells you to, seizure precautions in case the patient would seizure, and certainly if there's vomiting, you could give them an antiemetic. Household products and industrial chemicals, we're talking mostly about corrosives and poisons. household products and industrial chemicals corrode metal. They destroy tissue on contact, so these would be our corrosives. They're either strong acids or strong bases. The corrosivity, or how corrosive it is measured on the pH scale. If the acid has a pH of less than 2, it's highly corrosive. If the base has a pH greater than 12.5, it's highly corrosive as well. And when you mix an acid and a base, you get a toxicity as well. Acids include cleaning solutions, toilet bowl cleaners, drain openers, metal polishers. Some foods contain acid. Soap and water is the most effective decontaminant. As far as internal decontamination, I would be contacting poison control rather than giving some sort of antidote of burnt toast and milk or something like that. It's best to contact poison control to see if there's any dilution that you can do with these household chemicals. Acids, if they get in your eyes can become necrotic. They can develop eschars. The cornea can be destroyed and lead to visual impairment. So in the mouth, you certainly can have burns of the mouth, the esophagus, and the stomach. And one of the acids that they address here is hydrofluoric acid. You can have acute and systemic toxicity. In other words, you may see the signs and symptoms of a hydrofluoric acid exposure suddenly. And as far as systemic, if the acid product gets on your skin, or you ingest it and eventually it gets into the bloodstream, it may affect your central nervous system, your cardiovascular system, rather than just burn the area that it comes in contact with. Hydrofluoric acid penetrates deeper than other acids. Dermal burns show a white, yellow, or a white underneath skin. Patients exposed to this for long periods of time may develop hypocalcemia and hypomagnesemia, which leads to cardiac dysrhythmias. And the antidote is if they've got a burn on the skin from this acid, to take your calcium gluconate and smear it over the skin burn. Bases include your alkaline metals. They can be very caustic. You find them in toilet bowl cleaners, drain openers, household bleach. They burn and they produce tissue liquefaction and necrosis, and bases have a tendency to burn and penetrate deeper than acids. Treatment is rapid external decontamination. Burns to the stomach are more severe than acid burns. Bases dissolve the protective mucus layer that lines the stomach, can lead to ulceration and perforation of the stomach. And a good example of a household base is an ammonia cleaner. Hydrocarbons, those include gasoline, kerosene, mineral spirits, paints. Some are combustible, some are flammable. The flammability depends on the boiling point, and the boiling point is not the temperature at which the chemical boils, or flash point. Flash point is what I'm talking about. The flash point is the temperature at which the chemical has to reach in order to give off fumes that will ignite. So as an example, ether is a hydrocarbon, and ether emits fumes that are flammable up to 49 degrees below zero. So ether is often used to start vehicles in the dead of winter, because even at 20 below zero, ether will be emitting fumes that will ignite. Where you look at something like turpentine, turpentine has a flash point of 91 degrees Fahrenheit. So it doesn't emit fumes that will ignite until it reaches 91 degrees. They're not water soluble, so they float on top of the water. They do affect the central nervous system when you inhale them and they get into your bloodstream. They can be absorbed through your skin. And again, include hydrocarbons and protoxins. The volatility of the hydrocarbon is measured by the vapor pressure, which indicates a risk to the respiratory system. The more volatile it is, certainly the more it gives off fumes and the easier it is to breathe in. Viscosity affects the aspiration risk. And huffing is certainly something that we see being done with hydrocarbons, particularly paints and paint thinners and gasoline. Huffing those fumes to get a high, but not understanding that huffing for the first time could create a acute bronchospasm, very similar to a severe asthma attack leading to death. Recognition of the inhalant is important, and you might recognize that somebody's huffing because they have the stains on their skin and their clothing, all around their nose and mouth. They have irritation sores around their mouth. You may smell the solvent that they've huffed. They'll have an altered level of consciousness, red eyes, runny nose, difficulty sleeping, or memory loss. Treatment might include gastric lavage, might include camphor, might include halogenated hydrocarbons, aromatic, or let me back that up. Gastric lavage is recommended when the hydrocarbon is camphor, when it's a halogenated hydrocarbon, when it's an aromatic hydrocarbon, heavy metals, pesticides containing hydrocarbons. They want to avoid epinephrine with hydrocarbon intoxication. Pesticides and nerve agents. We already talked about pesticides and nerve agents. I'm not sure why we're coming back to them again. They include your organophosphates, your carbamates, your insect sprays. They can be ingested, absorbed, inhaled, and they're much more toxic when they're ingested. The nerve signal travels along the neuron through an electrochemical mechanism, and the signal stops at the synapse. At the synapse, a chemical neurotransmitter is released from the neuron to travel across the synapse to the next nerve. Now, with pesticides and nerve agents, acetylcholine binds to cholinergic receptors, and the electromechanical pulse continues in the next neuron, or contraction starts in the muscle. Once signal transmitter and neurotransmitters are removed, it inhibits the enzyme acetylcholinesterase. So acetylcholine, essentially what they're trying to say is that when a person is exposed to pesticides or nerve agents, this is a cholinergic, and as a result, excess acetylcholine is produced, and this excess acetylcholine slows the heart rate down, makes everything wet, and so we'll see classic signs and symptoms of sludgeon. We'll see muscle fasciculations. We'll see respiratory arrest. Airway management is a priority. Again, they're going to be full of mucus and saliva and vomit and diarrhea and all these things. So aggressive management of all the secretions is important. Carbon monoxide. Carbon monoxide is a tasteless, odorless gas that we can have occur in home and heating and cooking appliances. At low doses, carbon monoxide resembles the flu, headache, nausea, vomiting, diarrhea. It leads to hypoxia because the carbon monoxide has a stronger affinity to the hemoglobin molecule than the oxygen does, so it bumps the hemoglobin molecule it bumps the oxygen off the hemoglobin molecule and causes hypoxia and then eventually asphyxia. The skin, the red flush skin, may occur at super high doses of carbon monoxide ingestion, like greater than 45% carboxyhemoglobin levels. You might see some red skin. The treatment is simple. Identify it with a CO oximeter clipped on the end of a finger, and once you know that the carboxyhemoglobin level is elevated, or even if you're not sure, treating them with 100% oxygen is what you need to do. Support them, monitor their heart for arrhythmias, and get them to the hospital. Methemoglobinemia occurs as a result of nitrates, and nitrates oxidize iron in hemoglobin. It can occur as a result of medication overuse. In rural areas, the biological processes of fermentation creates nitrites after the silos are filled with grain, and as the grain biodegrades, the methemoglobin is released. Peak toxicity occurs 1 week after being filled, and it results in what's called the blue baby syndrome. You develop cyanosis, and the administration of oxygen doesn't improve it because methemoglobin doesn't carry oxygen. Hypotension, dizziness, headache, nausea, vomiting, confusion, cerebral swelling, cyanosis, cardiovascular collapse, and asphyxiation because methemoglobin again doesn't carry oxygen. Slate gray cyanosis, respiratory distress, altered level of consciousness, anxiety, confusion, and stupor. The antidote for metglobinemia or methemoglobin in your blood is methylene blue. Cyanides. I'm going to pause one moment here. All right. I'm back at the last couple slides, and we'll wrap this up for the part one. Household products and industrial chemicals. We're talking about cyanides. You find cyanide in silver polish, in the pits of certain fruits. Rat poisoning, during electroplating, plastic manufacturing. Cyanide can be in the form of a solid, a liquid, or a gas. In gas, cyanide is found in the burning of synthetic materials. So in patients who have smoke inhalation, they probably have patients who have smoke inhalation probably have cyanide poisoning as well as carbon monoxide poisoning. Cyanides can be used to commit suicide. Again, they can be inhaled, they can be ingested, they can be injected. It is a systemic chemical asphyxiant. It stops the production of energy in the cell by an effect called oxidative phosphorylation. So oxidative phosphorylation is the process where cyanide prevents the production of energy in the cell, and the cell dies. The antidote, they're referencing an older antidote here. In the 1970s, a disgruntled Tylenol factory employee took cyanide and put it into capsules, blister packed it, sent it out over the United States. 12 people died from cyanide poisoning. Lilly developed a cyanide antidote kit. It's again very old medicine. It involves administering amyl nitrite and sodium nitrite as the first part, and then sodium thiosulfate as the second part. It is only FDA approved for known cyanide poisoning. We have nothing for suspected cyanide poisoning. Or in other words, you can't use this kit for suspected cyanide poisoning. It's old medicine. It's highly ineffective. It creates methemoglobin, which doesn't carry oxygen as well. And the modern antidote for cyanide poisoning is hydroxycobalamin. hydroxycobalamin is a single IV infusion, and it combines with the cyanide in the blood to form vitamin B12. And the only reported side effects with the administration of hydroxycobalamin include red skin and red urine for about a week. Sulfides, hydrogen sulfides, we find these in confined spaces, or in chemical suicides where somebody will, in a confined space, mix a bathroom cleaner with a hydrogen sulfide, and mixing the two together forms hydrosulfuric gas, which is deadly, lethal. So when responding to a scene of somebody found in a confined space, make sure that you size that scene up. Don't retrieve the patient unless you have an SCBA. Hydrogen sulfide has the odor of rotten eggs. And in patients who work around these odors all the time, they become nose blind to the odor. A good example is, certainly a hog farmer who works around hogs all the time doesn't smell the odor of the hogs, or a person who smokes cigarettes doesn't smell the cigarette odor that they have on them following smoking a cigarette. But people who are not used to these odors can get a good whiff of them because they don't suffer from nose blindness or olfactory fatigue. Signs and symptoms of sulfides include dizziness, loss of consciousness, nausea, vomiting, respiratory tract irritation, pulmonary edema, CNS depression, respiratory distress, seizures, and anaerobic metabolism, which will lead to metabolic acidosis. Treatment includes being supportive, managing life threats, high flow oxygen. The antidote is, again, amyl nitrate or sodium nitrite, and many times the administration is too late. So that ends the first part 1, and I will be recording part 2 shortly, which you should have by Saturday. So thank you, and we'll talk to you soon.